Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. I mean, childhood chickenpox is like this itchy, annoying rite of passage for most kids, right?
Yeah.
But if an adult catches it, the numbers are just staggering.
Oh, absolutely. I mean, adults account for only, 2% of varicella cases, but they account for 50% of the deaths.
50%. That is wild.
Yeah, it completely changes your perspective when you look at the raw data. When you examine the history of infectious disease, the textbook is incredibly clear on this. Of all the advances in medicine, none has reduced sickness and death more than widespread immunization.
Right, like smallpox.
Exactly. Smallpox has been completely eradicated from the planet.
Well, welcome to this deep dive, everyone. Today, we are giving you, the Advanced Practice Nursing, or PA student, a really focused one-on-one session to master Chapter 57 of Len's Pharmacotherapeutics.
Yeah, we're looking at the precise clinical decision-making framework you need for safe childhood immunizations.
Because to do this right, you have to perfectly align pathophysiology with therapeutic goals, drug selection, and obviously safe patient outcomes.
Right. And before we look at specific shots on the schedule, you really need to understand exactly what we're handing the patient's immune system. So we have 4 main pharmacological categories to start with.
Okay, lay them out for us.
First, we have killed vaccines. These are composed of whole killed microbes or just isolated microbial components. The surface antigen of hepatitis B is a classic example.
So the pathogen is completely dead, or it's just like a fragment.
Right.
So the body sees it, builds a defense, but there is 0 chance of that pathogen replicating and causing an infection.
Precisely. You contrast that with live attenuated vaccines. Now, these are composed of live microbes that have been intentionally weakened in a lab.
So they're still alive.
Yes, and because of that, they mimic a natural infection beautifully, which, produces a very robust, long-lasting immune response. But there is a massive clinical implication here.
Well, I guess immunocompromised patients.
Exactly. Live vaccines can be incredibly dangerous in patients who are immunocompromised.
Because their immune system is just too weak to handle even the weakened version of the virus, right?
Yes. Without a functional immune system to keep it in check, the attenuated virus can multiply in profusion and actually cause a severe disseminated infection.
Wow. Okay, so that makes perfect sense. What's the third category? Toxoids.
Yeah, toxoids. They address a totally different kind of threat. Some bacteria don't harm you by invading your cells directly. They harm you by releasing localized poisons.
Okay.
So a toxoid is a bacterial toxin that has been chemically changed to a non-toxic form. When you administer it, the recipient's immune system manufactures antitoxins.
So it protects against the injury from the toxin, not necessarily the bacteria itself.
Correct. Tetanus and diphtheria are prime examples of that.
Got it. And the fourth category operates on a completely different principle, right? Specific immune globulins.
Right. We aren't asking the body to do the work anymore with these.
But it's not building anything.
No. Immune globulins provide immediate passive immunity. These preparations are made from donated blood and contain a really high concentration of mature antibodies directed against a specific antigen.
Oh, I see.
We use these when a patient is in immediate danger and simply does not have the time to manufacture their own active immune response.
That distinction between active and passive immunity is huge. We'll definitely come back to that later. But first, let's talk about the administrative side. As a clinician, your documentation is your shield, right? But it's also a major safety mechanism for the patient.
It absolutely is. Under the National Childhood Vaccine Act, you must keep a permanent medical record of every mandated vaccination.
Right.
You are legally required to document the date, the route, the site, the vaccine type, the manufacturer, the lot number, the expiration date, and the name and title of the administrator.
That just sounds like a mountain of paperwork. Why are we tracking lot numbers and expiration dates with such intense scrutiny?
Well, it serves 2 vital purposes. Obviously, we track it to ensure the child gets the appropriate series on time. But clinically, it's to avoid overvaccination.
Oh, giving too many doses.
Well, giving too many redundant doses of the same antigen significantly increases the risk for hypersensitivity reactions. We also have a mandatory reporting structure through VARs.
the vaccine adverse event reporting system.
Right. You must report severe events to help public health officials identify potential risk factors or, problematic vaccine lots.
Okay, so if a child has a severe reaction, it gets logged. But let's say a rare severe reaction does happen and a family is devastated. That's where the NVICP comes in, right? The National Vaccine Injury Compensation Program.
Yes, and it's vital to understand why the NVICP was established in the first place. Decades ago, massive civil lawsuits against vaccine manufacturers threatened to just drive them out of business.
Which would be terrible for public health.
Catastrophic. If they stopped making vaccines to avoid litigation, the global public health consequences would be unimaginable. So the NVICP was created as a no-fault alternative.
So it compensates families.
Exactly. It compensates families for legitimate vaccine-related injuries without destroying the fragile global vaccine supply chain.
That is such a brilliant public health compromise.
Yeah.
And to make sure parents are informed before anything happens, the law requires you to give them a VIS, right? A vaccine information statement.
Yes.
And not just at the start of a series. You have to give it to them before every single dose.
It's totally non-negotiable in clinical practice.
That actually brings up a practical bedside question. We know these shots hurt. They often cause a low-grade fever. It feels incredibly counterintuitive not to just tell a parent, like, hey, give your baby some acetaminophen or ibuprofen an hour before the appointment to take the edge off. Why don't we do that?
I know, it is a very common, well-intentioned assumption. But prophylactic painkillers can actually interfere with the very thing we are trying to achieve.
Wait, really?
Yeah. The text highlights evidence from a clinical study in Russia indicating that giving analgesic antipyretics before or shortly after vaccination can actually reduce the body's immune response to the vaccine.
So you're saying that Tylenol literally prevents the vaccine from working as well?
It blunts the antibody response, yes. And what's worse, the study showed that giving these drugs prophylactically didn't even significantly reduce the incidence of fever or pain in the first place.
Oh my gosh. So you're compromising the efficacy of the vaccine for virtually no clinical benefit.
Exactly. Routine prophylactic use should be strongly discouraged. They should only be used after the shot if a fever actually develops.
So what do you do for the pain then?
If you want to manage pain at the time of injection, rely on physical strategies. Hold the child upright, provide tactile stimulation near the site, perform intramuscular injections rapidly without aspirating first.
Oh, right.
And if you are giving multiple shots, always give the most painful injection last.
Okay, that makes sense. Let's apply that critical thinking to Table 57.1, true versus false contraindications. This is really where a clinician earns their keep,
Yeah.
You can't delay unnecessarily, but you also cannot give a shot when it's genuinely dangerous.
The rule for a true contraindication is highly specific. It's an anaphylactic reaction to a specific vaccine or a vaccine component.
Just anaphylaxis.
Yes. If a patient goes into anaphylaxis, that specific vaccine or any future vaccine containing that substance is absolutely contraindicated.
But false contraindications are where we see dangerous missed opportunities, right?
Yeah.
Practitioners sometimes inappropriately delay vaccination because a kid has, a runny nose.
Right. And you do not delay vaccination for a mild acute illness, whether they have a low-grade fever or not. You do not delay for diarrhea. You do not delay if the child is currently taking antibiotics. You do not delay for prematurity. Preemies get the exact same dosage on the exact same schedule as full-term infants.
What about a penicillin allergy?
A personal or family history of a penicillin allergy is totally irrelevant to vaccination.
Okay, but what about the big one? Thimerosal. You get a parent in the exam room who is terrified. The mercury preservative causes autism.
Right. The text provides a very clear safety alert on this. The concern that thimerosal causes autism is completely unfounded, validated by multiple large, high-quality, peer-reviewed studies.
It's totally debunked.
Exactly. Furthermore, the United States has largely phased it out of childhood vaccines anyway, mostly to reduce overall environmental mercury exposure. The trace amounts still found in some multi-dose flu vaccines are well below FDA safety limits.
Wait, if multiple massive studies proved it was completely safe, why did public health officials phase it out? Doesn't removing it just validate the parents' fears and make our jobs as clinicians harder? They see it removed and think, I was right, it was toxic.
Yeah, that is a profoundly valid frustration for clinicians. It was a precautionary measure based on cumulative mercury exposure from all sources in a child's environment, not because the vaccine doses themselves were inherently dangerous. But you are right. The policy shift created a massive communication challenge. Your role is to calmly explain the science. The preservative was safe, the link to autism is biologically false, and today's childhood schedule is virtually thimerosal-free regardless.
Okay, so we've established that live vaccines carry specific risks, and we know how to navigate contraindications. Let's look closely at the major live attenuated vaccines, starting with MMR, measles, mumps, and rubella.
We have to understand the devastation these viruses cause to truly respect why the vaccine is so critical. Measles is airborne and highly contagious. The real danger lies in the complications.
Like what?
Encephalitis occurs in about 0.1% of cases, but it carries a 10% risk of death, and survivors often face blindness or profound deafness.
That's terrifying.
It is. Mumps causes severe glandular swelling, but can lead to acute aseptic meningitis, and in about a third of adolescent and adult males, orchitis, which is painful inflammation of the testes.
And rubella, German measles, is generally mild unless a woman catches it during her first trimester of pregnancy. Then it becomes fiercely teratogenic, causing severe birth defects like cataracts, heart disease, and hearing loss.
Exactly. Because of these risks, the MMR vaccine is essential. It's given sub-Q. Mild adverse effects include transient rash or swollen glands in the neck. We monitor for rare severe effects like transient thrombocytopenia,
Which lowers platelet counts.
right, which lowers platelet counts and can cause bleeding and anaphylaxis.
I actually want to clarify a classic clinical myth right here. The textbook notes that the measles component of MMR is produced in chick embryo fibroblasts. So a parent tells you their kid has a severe egg allergy. Is that a contraindication?
Historically, yes, that was the assumption in pediatrics, but modern immunology shows that egg allergy is not the culprit in MMR anaphylaxis.
That's not.
No, the leading suspect is actually a hydrolysis product of gelatin, which is used as a stabilizer. Most children with a history of anaphylactic reactions to eggs have absolutely no adverse reactions to MMR. The true red flag you need to watch for is a known severe allergy to gelatin.
Okay, that is a massive clinical distinction. Now, we also said live vaccines are contraindicated in severe immunodeficiency, but there is a glaring clinical exception when it comes to HIV.
There is. If a child has HIV, but the infection is asymptomatic, MMR should actually be given.
Wait, really? A live vaccine?
Yes. You want to vaccinate them early in the disease course before their immune system declines. The risk of severe fatal complications from natural measles is far higher than the risk from the attenuated vaccine at that early stage.
That is fascinating. Okay, let's move to varicella, which protects against primary chickenpox and later shingles reactivation. We started the show with that wild statistic about adults accounting for 50% of the deaths. Are there specific drug interactions we need to warn patients about with this one?
Yes, patients must avoid aspirin and other salicylates for 6 weeks post-vaccination.
6 weeks. Why?
This is due to the theoretical risk of Reye syndrome. If the child develops a mild case of varicella from the vaccine itself, concurrent use of salicylates dramatically increases that risk.
Okay, that's crucial to tell parents.
Yeah.
Now, the last major live vaccine is rotavirus, sold as RotaTeq and Rotarix. This one breaks the mold because you don't inject it, you give it orally.
Right, because rotavirus naturally infects the intestinal mucosa to cause severe dehydrating diarrhea. By giving the live attenuated virus orally, it replicates right there in the infant's gut, building robust local immunity exactly where the real virus would attack.
But because we are inducing replication in the gut, there is a very specific mechanical adverse effect to monitor for.
Right.
Okay?
Intussusception. It is a rare but life-threatening form of bowel obstruction where a segment of the intestine folds in on itself, much like a collapsing telescope. Because of this risk, about 1 in 50,000 to 70,000, the vaccine is strictly contraindicated in infants with a history of intussusception or uncorrected GI malformations. It's also contraindicated in infants with severe combined immunodeficiency, or SCID.
Okay. From systemic live viruses, let's move to localized bacterial threats that rely on toxoids and fractionated components, diphtheria, tetanus, and pertussis.
So diphtheria colonizes the airway, forming a thick, leathery gray membrane that can physically block breathing while releasing a toxin that damages the heart and nerves. Tetanus is caused by an endotoxin from Clostridium tetani found in soil and feces, causing rigid, painful muscle spasms.
Lockjaw.
Right. And pertussis, whooping cough, causes intense, exhausting coughing fits that are life-threatening for infants.
We use combination vaccines for these. But if you look at table 57.4 in the text, it looks like a typo. For babies, it's capital D, capital T, lowercase a, capital P. But for teenagers, it's capital T, lowercase d, lowercase a, lowercase p. What is the clinical logic behind the capitalization there?
It is actually a brilliant standardized dosing code. Capital letters indicate a full high dose of the antigen. We use DTaP with capital letters for diphtheria, tetanus, and pertussis for primary immunization in children under 7.
So they need the big dose first.
Right. We need those large doses to build the initial foundation of immunity. Lowercase letters mean reduced doses. So Tdap with a lowercase d and p is used for booster shots in adolescents aged 11 to 18. Their immune systems already know the pathogen. They just need a gentle reminder, not the heavy primary dose.
That makes total sense.
Yeah.
Now, because we are using the cellular pertussis component, little a in there, what are the specific moderate to severe adverse reactions we need to watch out for?
Watch for persistent, inconsolable crying lasting 3 hours or longer. Also, fever over 105 degrees Fahrenheit.
That's high.
Yeah, but the most severe reaction is acute encephalopathy. If a patient develops encephalopathy within 7 days of receiving a pertussis-containing vaccine, that is an absolute permanent contraindication for any future doses of pertussis vaccine.
Got it. So toxoids handle toxins. But what happens when a baby's immune system is literally blind to the bacteria itself? Because some bacteria wear, like, an invisible disguise.
Exactly. Bacteria like Haemophilus influenza type B Helub and Streptococcus pneumonia are coated in outer polysaccharide capsules. An infant's immature immune system just cannot recognize these plain polysaccharides, meaning they can't mount a defense.
So pharmacologists created a hack called conjugation. It's like taking that invisible bacterial disguise and slapping a bright, flashing neon sign on it so the baby's immune cells can finally see the target.
That is a perfect way to visualize it. Clinically, we covalently bind or conjugate those bacterial polysaccharides to a highly recognizable protein carrier. We use things like tetanus toxoid or a non-toxic variant of diphtheria toxin called CRM197. By attaching the weak antigen to a strong protein, it forces the infant's immune system to react robustly.
Let's look at how that neon sign tech is applied. The Hubba vaccine prevents pediatric meningitis and is known as one of the safest vaccines on the schedule. Then we have the pneumococcal vaccines, and we have to choose between PCV13 and PPSV23.
And the choice comes down entirely to conjugation. PCV13 is conjugated. Therefore, it works beautifully for infants under 2 years old to prevent meningitis, sepsis, and pneumonia.
And PPSV23.
PPSV23 is unconjugated. It relies on a mature immune system, so it simply does not work in children under 2. You reserve PPSV23 for adults and older, high-risk children.
Okay, we also use conjugation for meningococcal disease with the MCV4 vaccine. The text targets college freshmen living in dorms, military recruits, and patients without a functioning spleen. Now, there was a major safety update regarding MCV4 and Guillain-Barré syndrome, right?
Yes, historically, there was a precaution because of fears that MCV4 might trigger GBS, an autoimmune nerve condition, but public health officials conducted massive safety studies involving millions of vaccinated patients.
And what did they find?
The data proved that the incidence of GBS was no higher in the vaccinated group than in the general unvaccinated population. Based on that overwhelming evidence, the CDC explicitly removed the GBS precaution.
That is a great example of evidence-based practice correcting itself. Now, what about polio? The text specifies IPV.
IPV is the inactivated poliovirus vaccine famously developed by Jonas Salk. It's given sub-Q. It is vital to know that the United States only uses this inactivated version today. We completely discontinued the old Sabin live oral polio vaccine.
Why did we stop the oral one?
Well, while the oral version was great for mass global distribution, the live attenuated virus could rarely mutate back into a dangerous form, causing vaccine-associated paralytic polio.
Oh, wow.
Yeah, so by switching exclusively to IPV, we eliminated that risk entirely. The only specific precaution now is monitoring for anaphylaxis to the trace antibiotics used in its preparation, streptomycin, neomycin, and bacitracin.
Good to know. Let's move into our final group. Uniquely engineered vaccines for specialized viral targets, hepatitis A and hepatitis B. Hep A is an inactivated whole virus protecting against fecal-oral transmission. But Hep B is entirely different.
Hepatitis B is a marvel of recombinant DNA technology. We don't use the actual virus at all. Scientists take the genetic code for the hepatitis B surface antigen and insert it into ordinary baker's yeast.
Yeast. Like bread yeast.
Exactly. The yeast acts as a microscopic factory, churning out massive amounts of this viral protein. We harvest that protein and use it as the vaccine.
That is wild. We're literally programming yeast to manufacture vaccine ingredients.
It is incredible. But because it's grown in use, the clinical takeaway is clear. You must screen for a prior anaphylactic reaction to baker's yeast before administering the hepatitis B vaccine.
Makes sense. Next is HPV, the Gardasil 9 vaccine, which introduces another incredible technology, virus-like particles, or VLPs.
VLPs are essentially empty protein shells. Through engineering, they are shaped to look exactly like the human papillomavirus. The immune system sees the shell and attacks, building long-lasting immunity.
But there's no DNA inside.
Right, because they are totally empty, they contain zero viral DNA. It is biologically impossible for them to cause an HPV infection.
The clinical guidelines emphasize routine vaccination for both males and females at 11 to 12 years old. And I want to look at this because it requires a very specific conversation with parents. We aren't just preventing a virus, we are actively preventing cervical, vulvar, vaginal, and anal cancers. But the timing is everything.
Timing is everything because the vaccine is strictly prophylactic. It cannot clear an infection that already exists. It must be given before the onset of sexual activity to provide that cancer protection.
And there's a specific patient education point here about fainting, right?
Yes, during patient education, you must warn them about syncope. Teenagers have a strong tendency to faint after the HPV injection. Advise them to sit or lie down during and for 15 minutes after the shot to prevent fall injuries.
Excellent tip. Speaking of genetic blueprints, we have to briefly mention the COVID-19 mRNA vaccines from Pfizer and Moderna.
Right. mRNA vaccines don't contain the virus or even a VLP. They inject a tiny sequence of modified messenger RNA. This mRNA enters the host's cells and instructs them to manufacture harmless spike glycoproteins.
And the immune system reacts to those.
Exactly. The immune system recognizes these spikes as foreign, destroys them, and remembers them for the future.
Okay, finally, respiratory syncytial virus, RSV. The text discusses palivizumab, or Synagis, and nirsevimab. But wait, palivizumab isn't a traditional vaccine at all. Why is it in an immunization chapter?
This brings us full circle to our very first definitions. Traditional vaccines, like mRNA or VLPs, provide active immunity. They force the patient's body to do the work.
Oh, right.
Palivizumab provides passive immunity. It is a monoclonal antibody. You are directly handing the patient the finished protective antibodies.
Because they don't have time to build them.
Exactly. And because these injected antibodies naturally degrade over time, palivizumab must be given monthly and strictly during RSV season. It is a highly specialized therapy reserved for very high-risk populations, specifically premature infants and those with significant congenital heart or lung disease.
Wow. Okay. So what does this all mean for you, the clinician mastering this chapter? It comes down to the sheer math of community immunity. Every time you educate a hesitant parent by correctly distinguishing a true contraindication from a false one.
Yeah.
Every time you explain that the yeast in a Hep B shot or the empty shell of an HPV vaccine makes perfect biological sense.
You aren't just checking off a textbook requirement. You are actively reinforcing the invisible shield that protects the most vulnerable members of society. You are the barrier between a highly contagious disease and an immunocompromised child who is relying on you to get this right.
Before you go, think back to that broken arm on an X-ray we often use as a metaphor for medicine. A broken bone is visible, undeniable. But a prevented case of measles, a case of cervical cancer that never happens because of an HPV vaccine given a decade earlier.
You will never see the diseases you prevent. Your greatest victories as a clinician will be completely invisible. How will you measure your success when your ultimate goal is for nothing to happen at all?
We'll leave you to think about that. Thank you from all us here at the Deep Dive's Last Minute Lecture Team for your dedication to patient care. Keep diving deep.